delayed puberty is defined as the absolute absence of development of secondary sexual characteristics by specific ages. So for girls, that means a lack of breast budding by age 13. For boys, it's the absence of testicular enlargement by age 14. This delay relates directly to an abnormality in what we call the hypothalamic pituitary gonadal axis. But here's a really fascinating caveat for you. Pubic and axillary hair might actually still be present in these children. Why? Because that hair development is driven by adrenal androgens. That's a completely different pathway, which can just keep functioning even when the main pubertal axis is stalled out.
Moving right along to Section 2, Gathering Clinical Clues.
So once the mystery is officially defined, the real shoe leather detective work begins. A clinician doesn't just guess, right? They systematically gather evidence in 3 specific stages to rule out suspects. Step 1 is a deep dive into the patient's medical and family history. Step 2 is a highly detailed physical exam. And Step 3 involves utilizing targeted lab tests.
Let's look at that history first. A doctor has to check an incredibly diverse list of historical clues. They're asking, is there a history of chronic illness or severe infections? What about previous trauma? Or maybe treatments like chemotherapy and irradiation that could cause gonadal injury? They also have to look closely at the family tree, the heights of family members, the onset of their puberty, and even the fertility of female relatives. All of that can point toward familial disorders. Think congenital adrenal hyperplasia, autoimmune endocrine disorders, or even Fragile X syndrome.
Now, what's really interesting is how much a patient's physical proportions can tell us before we even draw a single drop of blood. By carefully measuring height, weight, and arm span, distinct growth patterns start to emerge. If a patient has what we call uniquotal proportions, meaning their arm span is actually greater than their height, accompanied by remarkably long legs, well, this is a major clue pointing toward hypogonadism. On the flip side, if we see severe growth retardation where the patient's height age is actually less than their weight age, the detective is going to suspect a growth hormone deficiency instead. During the physical exam, the clinician is also tracking exact hormonal footprints left on the body. They're specifically differentiating between androgen and estrogen effects. Androgen effects are your masculinizing signs: phallic growth, increased testicular size, voice changes, increased muscle mass, and even body odor or acne. Estrogen effects, on the other hand, include vaginal cornification, breast development, uterine size, and eventually the onset of menarche, which typically follows about 2 to 2.5 years after breastfeeding. But hey, the physical clues don't stop at hormones. The skin and the central nervous system offer these brilliant diagnostic shortcuts known as stigmata. For instance, if a patient has midline facial defects and anosmia, which, by the way, is the inability to smell, that directly links to Kalman syndrome. If the doctor spots cafe au lait spots on the skin, neurofibromatosis becomes a prime suspect. And an unusual tanning of the skin, that points straight to adrenal insufficiency.
All right, Section 3, Blood Tests and Bone Age.
Once those physical clues are collected, we need internal forensic evidence to back up our physical findings. Measuring plasma FSH and LH levels, which are hormones produced by the pituitary gland, creates an absolutely crucial fork in the road for diagnosing the delay. If the FSH and LH levels are low, it's called hypogonatropic hypogonadism. Basically, the brain isn't sending the signal to start puberty. But if the FSH and LH levels are high, it's hypergonatropic hypogonadism. This means the brain is literally screaming for puberty to start, but the gonads just aren't responding. Alongside this, clinicians will assess bone age and check estradiol, testosterone, prolactin, and thyroid levels. Which brings us to Section 4, Genetic Suspects. So when the gonads aren't responding, we often have to look at the chromosomes themselves to find the culprit in our clinical lineup. Our first major genetic suspect is the 45X karyotype. This is the most common cause of Turner syndrome. However, it's not always cut and dry. Girls who aren't diagnosed until they reach their teens might have fewer physical findings. And this is often because of mosaicism, where they actually have a mix of 45X and normal 46XX cells. If Turner syndrome is suspected, the clinician plays detective, looking for a very specific set of physical clues, or stigmata. They're checking for signs of short stature, a webbed neck, medically known as pterygium culli. What about a shield-shaped chest, pigmented nevi or moles, shortened fourth metacarpals in the hands, or even heart murmurs? There might also be a history of congenital lymphedema right from birth that helps close the case. Now, on the male side of our genetic suspects, we have the 47XXY karyotype. This indicates Klinefelter syndrome, which is actually the most common cause of testicular failure. Patients with Klinefelter syndrome are usually tall and thin, have small testes, may exhibit mild mental retardation, and might present with gynecomastia. And this whole area brilliantly illustrates just how complex genetics can be. Look at Swyer syndrome and androgen insensitivity. Get this. In both conditions, the patient has an XY karyotype, genetically male, but actually presents with a female phenotype. In Swyer syndrome, children appear female but fail to develop breasts or reach menarche at pubertal age. In androgen insensitivity, the patient also appears phenotypically female and has breast development, but they have primary amenorrhea and a distinct absence of pubic hair. Interestingly, in androgen insensitivity, LH levels are usually elevated, but FSH might be totally normal because estrogen from the testes is suppressing it. Another really tricky diagnostic comparison in boys is distinguishing between anorchia and cryptorchidism. Anorchia, sometimes called vanishing testes syndrome, is the complete absence of testes. But if a boy has normal external genitalia and the testes just cannot be palpated, it's far more likely to be cryptorchidism, where the testes are undescended or retractile. The key here is that in cryptorchidism, the Leydig cell function is compromised. This means they might achieve normal testosterone levels, but only because those pituitary hormones, FSH and LH, are highly elevated to essentially force the issue.
And finally, Section 5, the most common cause.
So, the crucial point is, after looking at chromosomal abnormalities, absent organs, and crazy complex hormonal feedback loops, what is usually the actual diagnosis? Well, despite all of these fascinating and complex genetic suspects, the single most common cause of delayed puberty, especially in boys who are brought to medical attention, is simply constitutional delay. It's exactly what it sounds like, a natural, biological, late start. Clinicians identify this by noting a family history of delayed puberty, a completely normal physical examination, and a consistent growth velocity. The definitive clue? The patient's bone age perfectly matches their height age, both of which are simply trailing a bit behind their actual chronological age. All right, we've covered the established clinical evaluation, but I want to leave you with a final provocative thought based on some emerging research. We know that environmental chemicals, like bisphenol A, phthalates, and pesticides are being implicated in testicular dysgenesis syndrome. While the evidence right now is only suggestive and not completely conclusive, it really forces us to ask, could these modern environmental endocrine disruptors be actively altering these clinical timelines in the real world? It's a question that keeps endocrinologists